Thanks for the invitation. Yes, I'm going to talk about triple modality reconstruction, in particular in the application of theranostic using Y90. So when we talk about theranostic, we think about a treatment for cancer where you inject a patient with a radiotracer that will travel toward the tumor. And then we can also take advantage of the radiation created to do imaging and so monitor the treatment. But you can also use similar radiotracer to perform dosimetry planning. And so, yes, we can use PET-SPECT to do that. So quantification in this case is very important. As we know, PET-SPECT are relatively low resolution modalities. So it can happen that we underestimate activity in tumors. And so if we rely on this for treatment planning, we might undertreat the tumor and this affect the patient survival. There are, in the market, there are already triple modality scanner, both preclinical and clinical. We have one at the National Physical Laboratory. And so we can actually investigate whether we can take advantage of all the three modality information to improve both quantification and image quality. There are a different selection of theranostic radionuclides. However, I focus on Y90 for different reasons. The first is that you can potentially acquire both PET and SPECT data in parallel. It is clinically, it is commissioned by the NHS routinely. And also it was fairly easy for us to acquire data at the National Physical Laboratory with the Medizoni scanner. So Y90 is used for selective internal radiation. For selective internal radiation therapy to treat liver cancer metastases, in particular those ones that have extended from colorectal cancer, which is the third most common cancer in the UK. It is directly injected in the hepatic artery using a solution with resin microsphere, and the Y90 is attached to this microsphere, and they will travel directly and deposit around the tumor. So in this travel, they emit beta particles and they interact with the tissues, producing Bremsstrahlung radiation. Now, thanks to this radiation, we can acquire SPECT data. However, it is not a standard SPECT data because it is characterized by a very wide energy spectrum. And so this makes really challenging to do attenuation correction, scatter correction, but also a detector response modeling. A very small portion of this decays goes also through internal PET production, which makes the PET data feasible, the PET acquisition feasible. However, we only have 32 per million decays, so the PET data is going to be very low count. So the objective of the study obviously are to try to improve accuracy and image quality using different combination of extra information. And I want to highlight that we need both quantification and image quality because, of course, we want to estimate to better plan the delivery of the dose to the tumor. We want to have an accurate measure of the activity, but we also want to see the tumor, otherwise we can't do any measurement. So the strategy for the reconstruction was first to start with the Bremsstrahlung data and use CT information to improve over this. And also because we have an iterative reconstruction, we want to exploit the information that we get iteration after iteration. So the image that we get, we can then use it to as extra information for the PET reconstruction together with CT, and again the iterative update for the PET. Now you may be asking why why on earth would you start with SPECT to improve PET? Obviously, yes, I did have the same thought. However, I found this quite interesting and something that no one ever investigated. Also, some logistical problem. At the beginning, we didn't have triple modality patient data, so we only had SPECT data, so that was kind of easy. So the algorithm used for this is the multiplexing hybrid canalized expectation maximization, which allows to use as many extra information as we want with there is a constant kind of information, which is usually anatomical information. And then the iterative part is updated iteration after iteration. So yeah, okay. So as I mentioned at the beginning, we didn't have triple modality data for the patients, for the clinical study. So, but we did have an IMA phantom acquisition without Medizoni scan SPECT PET-CT. So we started trying to optimize the reconstruction there, and then also use the 5 patient data that we got from the Royal Surrey Hospital. And so after a few reconstruction, I realized that the HKM in this case, so in this case, I was using HKM with CT information. I realized that there were some artifacts at the later iteration. If you can see some here, and also the smallest lesion is likely deformed. And so this is related to the updated information in the kernel. So I thought to investigate whether by freezing this information to a certain iteration could actually improve this artifact. And so I then used this frozen version of the HKM, where basically instead of updating the kernel matrix every iteration, we decide to freeze these at a specific FN iteration. And so a few iterations were used to see whether we have a lot of change in quantification. However, you can see that in terms of mean values for region of interest, you don't really see a lot of change in activity unless you look at the first iteration. When we stop at the first iteration, it's clearly a bit too early. But otherwise, you can see maybe you can see that the coefficient of variation is actually reduced in the whole process. And when we okay, first of all the other parameters for the kernel were also optimized in a similar way. So trying to get the setting where you get the highest mean and the smallest coefficient of variation. So after all that, we compare the frozen and non-frozen HKM and OICM with and without PSF. I need to mention that clinically, the PSF is not actually used, and this particular PSF here was measured with Y90 specifically, because it is very different from what you would get when using technetium, for example. So from this result, we can sort of see, it seems like actually the frozen version in red, it's sometimes providing higher uptake and less noise. Well, you can also see it in the images. So I was kind of optimistic about that. However, when we look at the patient data, these are just 4, but just because I couldn't fit the 5th. But we can see that the noise level is clearly reduced, but in terms of mean value, we don't really get any increase. And if we compare with the vendor software, which are these black lines, and so at a specific coefficient of variation, then actually the HKM reaches that point in fewer iterations. So from visual point of view, we have two patients. So we can see the vendor and OICM are quite blurry. When we use OICM, contrast improve a lot. However, it's still a bit noisy. And then the two HKM are quite similar, though one is a little bit more noisier than the other. But when we look at the optimum iteration, so we stop at the optimum iteration for both HKM and HKM, then we basically don't see any difference. So in conclusion, for the first part of the study, well, first of all, we can see that we can improve over the normal, I mean, the standard reconstruction that is used in the hospital by up to 50% for the phantom and 47% for the patient data. The frozen version of the HKM can reduce noise and make the algorithm more stable with the iteration. However, it doesn't really provide any quantitative benefit. So for the next part of the study, I actually didn't use, I actually did use the frozen HKM. I used both and then saw the same results. So I basically didn't include that in the results. So I mentioned we have a scanner, the Mediso AnyScan Trio, that was previously implemented in the software photomographic image reconstruction. We have a NIMA phantom with 6 spheres and also a cold lung equivalent insert at the center. Yeah, and for the reconstruction, I use pretty much the same setting that were discovered in the previous study. So the SPECT image was reconstructed, and the 10th iteration was used as prior information, you can say, for the HKM. And for the PET reconstruction, then we can investigate different options. So we have SPECT-CT and PET information, SPECT and PET, CT, PET, SPECT-CT, only SPECT, only CT, and the 2 OICM. The CT image used here was modified to include some differences between the PET and the CT. So from this preliminary study, the main result were that whenever we don't use the PET iterative information, the lesions are the image are quite blurry in general, and there are also some artifacts in the biggest one. And when we use CT information, we saw some artifacts coming from the lung insert. Can you see? I think you can see this. So instead, when we use PET and SPECT information, the artifact doesn't show, and in terms of quantification, we get exactly the same result. So for the clinical investigation, we got 10 patients. Unfortunately, they were not acquired with the same scan. PET and SPECT were not acquired with the same scanner, so they were acquired at the Oxford University Hospital. G Discovery 710 was used for the PET and Discovery 670 for the SPECT. These patients were treated with SIRT, and so the data was acquired after 18 hours of the treatment, starting with 15 minutes per bed position of PET, using 2 bed positions, and then 30-minute acquisition of SPECT using a medium energy collimator and energy window between 50 and 150 kV. So obviously, when comparing this to the NIMA phantom, there are some more level of difficulties because we had to rely on registration. Obviously, the patient needed to go from the PET room to the SPECT room. So you can expect that they're not going, the CT images acquired there and the SPECT and PET data are not going to be perfectly register. And also the PET data is acquiring two bed positions, so you need to reconstruct both positions separately, then combine them and register with CT and SPECT. In terms of region of interest, we chose two different regions of interest. One is not the biggest nor the hottest lesion, but it's a lesion that is close to the liver, to the edge of the liver, because I wanted to investigate how CT information affect these kind of lesions. And the other one is the one with the hottest voxel in the region, and also most of the time is also the biggest. And we have a background region of interest to study the coefficient of variation. Once we reconstruct all the patient data, we can compare all the algorithms. And yeah, I need to mention also that we are comparing with DG Reconstruction. Here, the dashed lines, which was, in this case, this was optimized. So the beta factor parameter was optimized in terms by the group in Oxford in terms of image quality. So we use that one as comparison. So we can see that the green plot is always providing, now I'm not showing all the 10 plots, but they are quite consistent. So the green one is always providing higher uptake, which is the one using PET-SPECT information. Yeah. So that result was for the lesion L1. Is there a way to remove this thing?
I think you have to click on the chat and then it will disappear. Yeah, and now you close the chat.
Okay,
yeah.
Okay, cool. So yes, this is for the lesion L1. And so if you look at the images, these are two different patients. Here we are looking at this lesion here, which looks okay in this image. But whenever we have CT information, the lesion is quite deformed, and it seems like the activity is pushed over the edge, which obviously affects the quantification. And also it's something that we don't really want if you want to measure the size of the tumor or whatever measurement we should do. And on the other patient, the lesion is a lot bigger, so it's not as much affected, although the contrast is visible. The contrast difference is quite visible. But what is interesting is that whenever we use PET and CT information, for this patient, we see this deformation, and for this one, we really don't. So, and I think the reason here is, first of all, well, the lesion is a lot bigger in this case, but also it is more close to the edge of the liver. So somehow, in this case, the SPECT information is providing enough to not change the shape or the activity. So for the other region of interest, L2, we can still see that all the HKM are providing increased activity over Q-clear and OICM. However, between them, the differences are really, really small, which is kind of what we expected, because these regions are very big, and they are bigger than the neighborhood that we use in the kernel. So we don't expect a lot of oversmoothing when using the CT. So when we look at the bigger picture and of all the patient data, we want to understand whether these differences are significant. So a PET test was used in this case for both the regions, and for the lesion L1, which is the one close to the edge of the liver, we can see that all the algorithms actually provide different, significantly different results, while on the other, for the other case, the HKM different options are pretty much the same. They're not significantly different in this case, but they are significantly different from OSCM and Cochlear. So to summarize, we got quite a consistent result between Phantom and patient. We did see improvement in using these all the three modality information, especially in the case when we only use PET and SPECT information, because but I need to remind you actually that the SPECT information was reconstructed using CT information. And so this was better because we could reduce those artifacts that came from the CT. Another interesting point is that, I didn't mention it, I forgot. The Cochlear reconstruction was performed using time of flight, and all the steer reconstruction were not. So this, and we still improve. And so when we can use time of flight in steer, I expect this will further improve our results. And so in this study, I only show the improvement of the SPECT information to the PET image. However, we obviously want to understand the other way around as well, and we have a project, a PhD project now looking at the PET-SPECT joint reconstruction to this purpose. And so as a conclusion, so this result actually makes me very optimistic that we can, we have the potential to improve on all the other used theranostic radiotracer, especially when we rely on an image to plan the activity to be, the dose to be delivered to the tumor. I think this is the end. Yeah, thank you.